I'd like to introduce Eric Nussbaum to you. He is currently an athletic trainer at Colts Neck High School in Colts Neck, New Jersey. He's been an athletic trainer for over 25 years. He has worked at the collegiate, professional, and secondary school levels. He is currently the president-elect of the New York Trainers Society of New Jersey. So it's my pleasure to introduce Eric Nussbaum.
Thank you. It's like survival of the last remaining athletic trainers. What I'd like to do, try to accomplish with this workshop is kind of provide A to Z care of adolescent stress injuries, and particularly pay a lot of attention to the National Stress Fracture Registry, which is a registry that we did over the past couple years. Kind of got into the whole thing with adolescents when I made the transition from the college setting to the high school setting. One of the biggest things that kind of hit me in the face when I started dealing with the high school population is the number of kids that came in with sore shins and just this chronic bony pain. I'd seen stress fractures on the collegiate level, but I'd never seen it to the same extent that I was seeing it at the particular high school I was at. Kids had prolonged pain. There was several cases that went on to become complete fractures. There was definite performance declines with the kids. And there was kind of like a generalized lack of interest from the medical community to really look at these things and really work them up. It's not a surgical case for the orthopedist, so why should he put a lot of time into really looking at it? With my background as a college athletic trainer, when kids were hurt, you'd push to get them worked up and to get them evaluated. So I took that mentality to the high school. And with that, there was a lot of surprising results when it came to stress fractures. That got me thinking, why are we seeing so many problems with the adolescent population? And what are the long-term consequences for these kids as we look at it over time? A little quick review. 50% of all injuries seen in a pediatric sports medicine clinic are related to overuse. 50% of stress fractures occur to the age population under the age of 20. And 40 to 50%. There's a high number of stress fractures occurring to the adolescent population. When I asked my friends, like that were in the high school setting, how are you dealing with these things? Are you seeing a lot of stress fractures as well? Got some interesting responses. One of them said, they're just a pain, it's just a matter of them just doing too much activity. I just put them in a cold whirlpool, make it so cold that they don't come back and bother me anymore. That's not a real good thing to do. Other one said, I just tell them to stretch and give them a little arch support and they'll be fine. But a podiatric friend of mine said, it's just a matter of simple levers. It's a pretty simple problem, pretty simple answer. One of them, I have to give him credit because I think it's a great statement. Shin, what's a shin bone? It's just a device for finding furniture in a dark room. It's funny how some athletic trainers hardly see any stress fractures at all, and then other places you see you find a lot. And I wish I had $1 for every script that I got that came back with a diagnosis of shin splints. Just irritates me because there's no medical description or formal description of what a shin splint is, yet it's the most common diagnosis we see in the adolescent population. And I think there's just a general lack of knowledge and understanding. So it started me down the road of research, looking for answers, trying to find out why there was all these causes and what was going on. I think there's a lot of different factors that you have to start thinking about as you start looking into the literature, the structural, the biomechanical, vascular, hormonal, neurologic. There's a lot of different factors that are all playing into the whole picture. Luckily, I was fortunate to work with a great team physician who's an orthopedist and happens to be chairman of the orthopedic department of the medical school at Robert Wood Johnson, which is our big university hospital in New Jersey. And through working with him, he took the interest to work things up. He's also a former runner himself, or a current runner. I shouldn't say former because it's a lifetime sport, right? So he took the interest in taking the kids and really working them up. And I think it was a lot of feedback that I had with Dr. Gatt, which helped to kind of spur my interest as well. So I've asked Dr. Gatt to kind of help out with this talk, with this presentation, and he's going to talk a little bit about some of the components that are associated with stress fractures.
Thanks for having me this evening, I should say. So today I'm going to talk a little bit about my clinical perspective on adolescent stress fractures, kind of a little bit of a spillover just into overuse injuries in general in the adolescent population. I'm an orthopedic surgeon, but I'm also a Pop Warner football coach, and as Eric said, I am a runner right now. So I'm used to dealing with overuse injuries and used to dealing with a lot of parents even calling my house on weekends and asking me about their kids' pains in their ankles or their shins or whatever the case may be. So in working with Eric, I'm kind of getting an even better understanding of all this stuff, and hopefully we can come to some better conclusions and help take care of the kids better. So overuse injuries are I think, are becoming a bigger problem, and there are those that would say it's almost becoming an epidemic nationwide. And in my competitive little town of Montgomery, it's certainly, I can see the problem growing already. So we know that right now 30 million kids participate in organized sports right now. There's no more pickup games in the high school yard. Everybody belongs to 2 or 3 teams, and they do it year-round. And you just see that number probably growing every year. Participation in high school athletics is increasing. The number of kids out for a high school team, for all the high school teams, is just ridiculous. More than 7.3 million high school students participating annually. That's a huge number. I mean, I've heard of high school track teams having 75 kids to 100 kids going out for track, which I think is pretty big. And these are, they're big schools, but still, that's a lot of people. And it's good because we want the kids involved in sports, but the intensity that they participate in them is certainly much higher. We're also seeing that the younger athletes are specializing in sports at a much earlier age. I mean, we have, a boy will tell you, at 12 years old, I'm going to be a pitcher, and he has a year-round baseball pitcher coach, and that's all he does. I don't know that that's necessarily the right thing, and that's probably another reason that we're seeing these overuse injuries. And then these speed and agility training opportunities are just are exploding. So you have a child who's on the Pop Warner team or on the soccer league, and at nighttime he's going off to the speed and agility coach to get trained 2 or 3 times a week. So the amount of effort they're putting into their sports at such a young age is probably much different than, it certainly is much different than when I was, in that age group. That more than 3.5 million children under the age of 14 are treated annually for sports injuries, and that overuse injuries account for half of all sports injuries in middle and high school sports. High school athletics account for more than 2 million injuries annually. That's 500,000 visits to the doctor and 30,000 hospitalizations, so all related to high school sports. So I don't want to dwell too much on overuse injuries. We're going to talk about stress fractures. And just a little quick refresher on bone. Bone is made up of 2 components, the cortical or the outer shell of the bone. The cortical bone is the dense, highly organized, strongest part of the bone. It withstands compression forces primarily. Bone really isn't subjected to tension very much. It also has to resist the torsional forces on bone. The element of the bone, what makes up the bone, is the small osteons, which is made up of eversion canals that allows nerves and blood vessels to traverse through the bone. I mean, bone is a constantly remodeling tissue. Nutrition and metabolic transport occur within the bone. It's important in terms of your calcium homeostasis in your body. But it's a metabolically active tissue, and that's probably plays some role in what's happening with stress fractures. Inside the cortical bone is the cancellous or the trabecular bone. It's an irregularly shaped mesh of bone. The trabecular density is basically aligned along force lines. So, like in this cutaway of the femoral head, where the forces go down from the top to the bottom, you can actually see the trabeculae line up, and they're more dense up in the metaphyseal or the long ends of the bones. In the shaft of the bone, like in the mid-shaft where we see like the tibia stress fractures, there really isn't a tremendous amount of cancellous bone. It's much less dense. So bone is dependent on the health of bone, and the strength of bone is dependent on numerous factors: the material properties, the degree of mineralization. We don't really think much about mineralization. You think about that more in osteoporosis in older women. But I think if we were to look at a lot, especially the younger females who are dealing with overuse injuries or a high incidence of stress fractures, and we were able to collect a good amount of data on that specific population, we find that they're probably starting off life with a lower bone mineral density than they should, which, as probably many of you know, has its consequences later in life. Collagen characteristics: there are diseases, primary diseases of collagen. Osteogenesis imperfecta, which is a brittle bone disease, is actually a genetic defect in collagen production. Osteocyte availability: how many cells are in the bone. Then the structural properties: how big are the bones? I mean, we see kids with little small bones, and I see the X-rays with their narrow bones. There's certainly The smaller the bones are, the more susceptible they are to fracture. Maybe not stress fractures, but per se, but certainly for traumatic injuries. Then bone is subjected to all different forces, and compression forces primarily. I mean, that's basically what bone is designed to resist. Bone isn't designed to resist tension because we're not trying to pull our bones apart per se, but when bones are subjected to bending, they see both tension and compression forces. So for instance, in the femoral neck, the bottom of the femoral neck sees compression forces while the top of the femoral neck sees tensile forces. The same thing in the femoral shaft. The femur has an anterior bow, so the posterior femur sees more compression forces. The anterior aspect of the femur sees more compression forces. It is subjected, the bone is actually very weak in torsion. That's why we see so many spiral fractures. And then shear is just a component that you don't really shear the bone, but torsional forces result in shear forces in the bone. So bone also isn't really very strong to resist shear forces. So again, it's a dynamic structure, and bone remodels in response to Wolff's law. In other words, if a bone doesn't see any load, then it's not really that strong. If bone sees load, it remodels the bone along the force line. So the more force, if a bone's seeing more force on the outer side or the lateral side, it's going to be thicker and stronger there than it is on the medial side. It remodels by the osteoclasts, they're big multinucleated cells that eat up the bone and then deposited by new bone is deposited by osteoblasts. And there's an interaction between the two cells. So for instance, when we again look at why people have osteoporosis, it's because the osteoblasts are eating up the bone faster than the osteoclasts are taking care of the bone, or osteoclasts are eating the bone faster than osteoblasts are laying it down. And the treatment, when women are taking the bisphosphonates, what they're doing, it's an osteoclast inhibitor. So that medication is preventing the osteoclast from chewing up the bone, and then the osteoclasts are able to keep pace. But what we're seeing, and just to show you why this would have an impact on stress fractures, women who have been on Fosamax for more than 5 to 10 years are at risk for atypical stress fractures. And the reason being is their bone's not going through the normal remodeling process. The osteoclasts have been slowed down. The osteoblasts are still working at their normal pace, but they're not laying down the bone along the normal force lines because it's not being resorbed by the normal force line. So what bones see in terms of forces is important in terms of how they remodel and how strong they really can be. So let's focus on stress fractures now. And what are they and what did we know? I think Eric pointed out very nicely that it's really something we don't know a lot about. I mean, it's a syndrome that I find the primary care physicians, like the pediatricians and family medicine docs, I mean, they send them to me and say he has shin splints, or they don't even tell you that. They don't send them to an orthopedist. They say, oh, your son or your daughter has shin splints. Tell them to take 4 weeks off and let him start running again. And that's about the treatment that's rendered by a doctor's office. I can't see that that's the right answer. These kids want to compete, and that's probably the answer that's going to drive them away from their sport. So I never use the term shin splints, and when parents come in and say their kids have shin splints, I say we don't use that term. We use the term stress reaction, because that's really what's happening. There's a reaction in the bone related to the stress that the bone is seeing day in and day out when they're in their sports. And the way I try to describe it to parents and kids to make it simple is I say stress fractures, when you're out running every day, you're causing tiny microscopic cracks in your bone, and at nighttime your body heals them, so you don't know it, your body doesn't know it, and everything's fine. But if you start to develop more micro cracks and your body heals at night, all of a sudden you're a little sore at the end of practice, then it's the middle of practice, then you're limping around school. And that's, I think when I start to explain it that way to them in a way that I think they understand, they start to understand, how I'm going to treat them going forward. And one of the things that we're seeing with the scientific studies is that it's probably an exaggerated metabolic response. The bone's trying to heal itself, but it's increasing vascularity, the osteoclasts are cranking up a little bit, and we're trying to find out, is there a way to stop this from happening so that stress fractures don't occur so much? So what do we know about the mechanics? Well, as I said, bone is stronger in compression than it is in tension. But we see stress fractures primarily on the compressive side of the bone. So you see your typical posteromedial tibial stress fracture. That's the most common thing we're going to see. That's the compression side of the tibia. But what's the stress fracture that we're most concerned about is the anterior tibial stress fracture, the dreaded black line, which is on the tensile side. The same thing in the femoral neck. If you have a runner with hip pain, you send them for an MRI, 9 out of 10 times it's going to come back compression side stress fracture. That's where bone's stronger. But we get really worried about a tensile side stress fracture. Actually, that's one that requires somewhat urgent surgical treatment. So it doesn't make intuitive sense that the stress fractures would occur in the stronger mode of the bone. One of the studies shows that if you just cycle a typical tibia for, in physiologic loading that's associated with running, it would take 10 to the 8 cycles. That's a lot of running. But we see that biomarkers for stress fractures starting to occur as early as 2 weeks. And we know that the clinical symptoms, when's the worst time for stress fractures? 3 weeks into the season, right? Mid-September, that's when all the kids are coming in with my shin hurts or my foot hurts or whatever. And so it's a lot earlier than they haven't pounded on their leg 10 to 8 times. I can guarantee you that. So again, what's causing this? Why are we seeing markers of stress injury to the bone as early as 2 weeks? We really don't know the answer to the question. In the bottom of the slide there was, in one of the military studies, they said, well, if stress fractures occur most commonly at 3 weeks, let's give everybody a break at 3 weeks. And that didn't change the incidence of stress fractures. It was still the same. So actually the physiologic process that results in that is going on much earlier. So then I talked about bisphosphonates. So maybe if we could decrease this metabolic activity of the bone, maybe that would prevent them. So again, most of the work that I'm citing here that's scientific is from the military. So bisphosphonates inhibit bone resorption. They actually stop the osteoclast from working, but they also inhibit bone remodeling. So in a rabbit model, where they were able to induce a stress fracture when they gave bisphosphonates, they showed that that could decrease bone scan activity, so the bone was less metabolically active. So in the military, they said, well, let's try it. Let's put our recruits on residronate, which is one of the older bisphosphonates, and that had no effect. And there's actually a question of it increasing the risk of stress fracture. And again, it probably goes back to that fact that the bisphosphonates are interfering with the normal remodeling process of bone. And that's probably what we're finding out with stress fractures. It's just an abnormal remodeling process. The bone's trying to remodel to all the stresses. It's just not doing it in the right way, but we don't know how to correct that yet. So again, scientifically, we really don't have a great answer as to why stress fractures occur. And then, the talk that Eric and I are giving today is on the adolescent population. So how much do we know about the adolescent population? I can tell you very little, if any. There's a relatively good base of information in the college population. So like from the 1AA powerhouse Lafayette, where I went, they did a 2-year monitoring study of 900 athletes. 6.9% of the athletes had stress fractures, 2% in females. I think we all know that it's much more prevalent in running, and you can see incidence rates as high as 20%, 25% of runners. And I think you could find hundreds of papers on stress fractures in college athletes, knowing that it's more common in freshmen and sophomores. It's more common with coaching changes. It's most common in track. We know all that stuff in the high school, but how does that play out in the adolescent population? Well, I tried to do as much of a literature review as I could do to find out about adolescent stress fractures, and there's almost none. This isn't even from the American literature. This is from the European Sports Medicine Society, a paper on adolescent stress fractures, and there were only 19 patients in the whole study. Most of them were tibia stress fractures. The highest incidence was in the tibial diaphysis. They occurred with stop-start sports. Found that the longer it took to diagnose the kids with the stress fractures, the worse their outcome was. And again, that comes back to what Eric and I have been kind of saying, is that a lot of the kids are going to their primary care docs who are just blowing it off. They're never making the diagnosis. The kids will continue to try to run through it, and then they can end up with months and months of pain, or ultimately decide, you know what, this isn't worth it, and I don't want to do sports anymore. And you're basically turning young kids away from sports, which really is not our goal. Here's another. This is probably this is in Journal of Pediatric Orthopedics. So this is out of Tennessee, and here's 32 patients, but half of these aren't even sports related. These are kids that were in the hospital with metabolic bone disease and everything. So you can't even find good data on adolescent stress fractures. So risk factors for stress fractures, again, I'm going to go back to mostly military data, but we think of the female athlete triad syndrome that everybody has heard about, and you think about amenorrhea, and is that a cause for stress fracture? Well, we do know that female athletes that are either amenorrheic or oligomenorrheic for more than 6 months have an increased incidence of stress fracture, but exercise alone doesn't cause amenorrhea. Again, this was more from a military study showing that it took actually a decrease in adequate caloric intake to cause the stress fractures in this population. So once calories were decreased and once the exercise was increased, and that's the things that led to amenorrhea or oligomenorrhea and ultimately led to stress fractures. And then also as terms of diet is concerned, military looked at lower vitamin D levels and lower iron levels. These were both risk factors. This is a study where they mandated that the recruits take 2,000 milligrams of calcium and vitamin D, and they were actually able to decrease the stress fracture rate by 27% in female military recruits. So that was a good study. It's, I think, again, in our high school population, the kids are going to the soda machine or drinking juice, and a lot of them, they've given up milk, very quickly into their adolescent years. Ask them how much milk they drink, maybe 1 glass a day, if that much. They say, well, I drink orange juice with calcium, but they don't get adequate vitamin D intake. So I do spend a fair amount of time with the kids in the office talking about sources of calcium. Hopefully their moms are there listening to the same talk, because it kind of spills over into osteoporosis. But we emphasize the importance of getting adequate calcium intake, and most importantly, getting good vitamin D, since we know you don't absorb your calcium if you don't get adequate vitamin D. So then, if I move on to X-rays, I get X-rays on the kids with stress fractures almost all the time. I mean, I have an X-ray machine in my office. Their parents kind of expect an X-ray. But truthfully, when they come to me early on in their symptoms, when they say my shin's been hurting for 3 weeks or my foot's been hurting for 3 weeks, I'm almost 100% sure they're not going to have a positive X-ray. But you do want to know, because if it's a more chronic type of problem, maybe they have signs that they've been dealing with stress fractures for a long time. So some of our research shows that less than 25% of X-rays are positive the initial time we take it, and that 50% of stress fractures will never be X-ray positive. But if you look carefully, there are some subtle signs. The things that I look for are periosteal new bone formation right on the edge of the bone, or a little bump that indicates a stress concentration center in the bone. And sometimes, if I'm not sending them for MRIs, I'll say, well, come back in 4 weeks. We'll get another X-ray, and a sequential film can be helpful, but you try to minimize the amount of radiation. So then there are things that we look for on both CT scan and MRI. I don't use CT scan very often. It's certainly a very high dose of radiation, and there's actually much more attention is being paid to the amount of radiation in CT scans recently by the American Academy of Orthopedic Surgeons. So I think in the adolescent population, you're really not going to try CT scan unless you're looking for something specific. And the most common reason that I would get a CT scan would be for a spondylolysis that may not show up well on an MRI or a bone scan per se. I tend to use MRI very frequently, and I find them very helpful. This is the MRI grading system that I think is the most commonly used. Grade 1 stress fracture would be just a little bit of marrow edema, not much change in the bone at all. A grade 2 would be primarily periosteal edema with a little bit of changes in the marrow, but not true, fully encompassed edema. And then a grade 3 stress reaction would be full-blown marrow edema and periosteal edema, and then a grade 4 stress reaction would actually be a visible fracture line on the MRI. We have this grading system. It's nice to know about, but it doesn't help me really predict. Does it really predict the severity or the duration? I can't really say that it does. It helps me with parents and coaches, because again, if I have a negative X-ray and the kid wants to play in the next soccer tournament or wants to keep on training, and I say, well, look, let's get an MRI and see how, what kind of stress reaction this is. If they come back with a grade 3, I'd say, oh, this is a grade 3 stress reaction. It's much easier for me to convince the parents to take them out of sports, as opposed to just saying, well, your X-ray's negative, but I really think you have a stress fracture. You probably shouldn't be doing it. And even the kids will buy into that, because they, especially when you do the tibias, they usually get both legs on the MRI. So I can show them and say, this is what a normal tibia looks like, and look at all this edema and swelling around your bone. And it kind of sells the point to both the athlete and the parents that something's wrong here. They've got to rest, or they've got to change their training regimen to get through this, or they can go on to a true fracture. So I'm going to show you a couple of them. These are cases that I literally just saw over the last 2 or 3 weeks. 12-year-old male baseball player, nothing out of the ordinary. He plays Little League baseball. He's on a travel team. And his dad tells me, yeah, he's been complaining about some right knee pain. He's having a little bit of difficulty running the bases. If he, a couple days off, he's getting better. He hasn't had any recent trauma, to his leg. No one slid into him. He's a catcher, apparently relatively good player, but he's only 12 and not a crazy parent, I can tell you that. So examine him. There's a little bit of swelling around his proximal tibia. He's definitely tender to palpation. I'm surprised at how much he hurts. No effusion in the knee joint. His knee exam is normal. I asked him to do a one-legged hop, which is a very common test for me. He can barely do a one-legged hop. I said, I don't know how you're running to first base if you can't even hop like that. His X-rays are completely normal. So I was actually semi-concerned about a tumor in this kid because of the level of pain he had. So I sent him for an MRI, and here's his MRI. So if you see on the left, he's got a grade 4 stress reaction. I saw nothing on X-ray. This was only a few weeks worth of symptoms, and this is just Little League baseball. I mean, I can tell you, if he had gone straight to his pediatrician, 95% of the time they said, take 4 weeks off, don't sweat it. And this guy's like, the batter's like, well, he's got a tournament coming up next weekend where he'll play for 3 days straight. Should he play? Well, I said, well, let's get the MRI. Now, I showed him this MRI. It was very easy for me to tell the parents and this 12-year-old boy, you can't play, right? I mean, that's pretty straightforward. Well, 2 weeks later, they were going on vacation to Italy, which obviously requires a lot of walking, and I was worried he could break this. I didn't put him in a cast or anything. I just told him no running, no jumping. And here's his x-ray 2 weeks later. I left the MRI on the left just so you can see that if you look at the proximal tibia, you can actually now see the fracture line. It's not a fracture line, but there's increased bone density indicative of the stress fracture. So as I pointed out, serial x-rays can come in handy, and the reason I got this was because if he had signs of a dreaded black line or there was a lucency in the bone, I probably would have put him on crutches for the trip to Italy or said you have to be a little bit careful about going over there. But he was becoming less and less symptomatic and got better. And I'll talk about my treatment regimen in a few minutes. Here's another one. This guy, this family friend, actually 16-year-old male, Division I soccer prospect. His older brother was on the Olympic development team. He's almost as good. But really wasn't having any pain. Had a simultaneous kick with another player and had lateral foot pain. It was more of a sudden onset. He was able to continue play, and he has a big upcoming showcase. But because his younger sister had had a stress fracture, they were a little bit concerned and brought him in to see me. Took x-rays and examined him. Maybe a little bit of soft tissue swelling, ecchymosis, again consistent with more of a traumatic injury. Tender over the 4th and 5th metatarsals, normal ankle exam, x-rays, totally normal. So I sent him for an MRI. If you look at his 4th metatarsal, grade 3 stress reaction. So now he's 2 weeks away from a showcase that apparently, according to his parents, is critical on him getting a scholarship for Division I sports. So what do? Do you let this kid practice for the next 2 weeks? Do you let him play 2 weeks in a 2-day showcase? That's where the dilemma exists. And when I have to tell a parent that this kid can't train or maybe can't play in this showcase, these MRI findings really come in handy. So treatment, what do I do? So if I have an athlete and I get a negative x-ray and I'm only mildly suspicious or I think they're in the very early stages of a stress reaction, I will kind of go over a concept of just activity modification. I'll tell the parents, look, clinically, I'm pretty convinced that if I were to send your child for an MRI, we'd probably see a stress reaction. It's not bad enough they have to come out altogether. I go through my talk about microscopic cracks and healing and all that kind of stuff, and I say, so we need to titrate your training to the point where you're getting better every week or in the worst case scenario, getting no worse. And if that's the case, you can continue to participate and will probably be okay. But I emphasize 2 points. The symptoms cannot worsen, and there has to be good communication. I tell the kids you can't not tell your parents or not tell your trainers that you're getting worse, because if that's the case, you're going to end up with a broken leg, you're going to end up with crutches for 6 weeks or something bad. But if I have a positive x-ray or I have a grade 4 stress reaction on MR, I'm going to tell them it's absolute rest and potentially put them on protected weight bearing. I'm not big on putting on people protected weight bearing. I'll just say, look, your stress fracture occurs because you're running and jumping. So if you just walk, you'll probably get better. But if 2 weeks from now or 1 week of just walking, you're not getting any better, then we're going to have to put you on crutches or possibly put you in a cast. And what that kind of does, even if I know they're going to get better with just rest and activity modification, that little fear that they might be in a cast or might be put on crutches keeps them off the field, which is a good thing. Then I see, in the college level, I'll say, well, is there anything I can do to make these stress fractures heal faster? For instance, you got this kid, the 16-year-old kid who wants to play in this showcase. Can I make his stress fracture heal any faster? There's really no data to show that we can change it in any way. Again, this is a naval study. They tried pulsed ultrasound. This is a blinded, randomized, prospective study. It's as good as it gets in terms of saying that you can that this is a real measure of if this is effective. And in 43 tibial stress fractures, they showed no improvement or earlier return to play or relief of symptoms. Other things that I've thought about, maybe calcitonin, which is something that promotes bone formation. It would be a possibility. Calcitonin's been used in osteoporosis patients and decreases their pain sooner, but doesn't show any signs of osteoporotic healing fracture. So we really have no good data to support any medicinal or modality use that's going to accelerate the healing of stress fractures. So I think the key, especially in my practice, is prevention. Because I deal with a lot of younger athletes. I talk to the parents a lot about it. I think dietary is key. Explain that if you're not getting adequate caloric intake for your level of sport participation, you're at risk. I emphasize the whole concept of preseason training. Say, know what your coaches expect you to do the day you arrive in the fall or the winter, and make sure you have an 8-week training program that gradually brings you up to that level. Look at new training measures. You don't just have to run and jump every day. You could ride the bike. You could ride the Stairmaster. You could run in a pool. And identify the athletes at risk. I mean, you can tell when you see girls that are fair-skinned, they don't get out in the sun, maybe they look a little too thin, kids that are just on 3 sports at one time. I mean, I can't tell you how many in the winter, girls basketball, the girls come and say, yeah, well, I'm on 3 basketball teams. The coaches don't know what the other coach is doing, so they're practicing their brains out. And communication, getting the kids to talk to their parents and talk to their trainers, and I think early diagnosis is key, because if we let them get into the late stages, they're reluctant to continue. The consequences are irreversible bone loss. We know within the gymnastic population, where the girl gymnasts are starting off with low bone density, they never recover that bone density. It never comes back. This is another European study that showed if you looked at them 8 years later, now they have normal menses, they're on oral contraceptives, and they're out of gymnastics, they still are at a lower bone density than the general population. That becomes an even bigger problem when they're 40 and 50 years old, and now they're susceptible to femoral neck or spine fractures. So these problems that we're dealing with at the young age are going to play out later in life if we just ignore them. And then the other consequences, people say, well, are you ever going to break your bone from a stress fracture? Well, I gotta go. How do I go back? Wheel it back. Can you start that movie from there? Because I don't see the mouse. There we go. Double click that, and it'll start.
42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 83, 84, 85, 86, 87, 88, 89, 90, 91.
The story on this girl, I think she had 2 to 3 weeks
92,
of mild shin pain.
93.
Nothing. It wasn't like a girl who tried to run through a season worth of shin pain. So, there are it's not like this doesn't happen ever. But there we go. Okay. So I think, that's obviously very dramatic, but the risk factors are that, overuse injuries are a risk factor, the most common risk factor for future injuries in both youth and adulthood. They can be contributors to long-term degenerative diseases such as osteoarthritis, but I think in my mind, most importantly, it's going to lead to the avoidance of recreational exercise by our young adults. If their initial experience with sports is that I get hurt by exercising too much, when they get older, when they really do need to exercise, like, forget it, I'm not going to do that, I just get hurt. So I think that's a crime that happens, especially as we deal with more and more obesity. So as a member of the AOSSM, I'm interested in youth sports. I think this is a real problem. We know that 70% of kids participating in sports are dropping out by the age of 13. Youth sports injuries are on the rise, and who can help? Parents, coaches, trainers, physicians. It's all communication. The AOSSM, actually in conjunction with your organization, NATA, and several other organizations, has started the Stop Trauma and Overuse Prevention Program, so they call it Stop Sports Injuries. This website just came online a few months ago. The AOSSM put about $500,000 into this project. They've gotten tremendous corporate support. They have names, big name athletes talking about this. And I think you're going to find this as one of the most comprehensive web tools you can use in terms of getting information about overuse injuries, stress fractures, things that you can help, in treating your athletes. I go to it, pretty frequently. They're on Facebook and on Twitter. If you can get your athletes even to buy into it and sign up as a friend on Facebook, they'll get little notes every day about, preventing overuse injuries, which is really what we need to see. The parents need to see it just as much as the young athletes do, I must say. There's sports tips. There's going to be video podcasts coming out, and there's going to be educational tools that we'll be able to use as physicians, care providers, coaches, parents, everybody. It's really just in its infancy, but it's starting to explode like right now. So, these are the organizations that are involved in it. I would, again, encourage you to take a look at this. I think it's going to make a big difference going forward. And their kind of mantra is, let's work together to stop sports injuries and keep kids in the game for life. StopSportsInjuries.org, a great website to start with. So anyway, that's it. Thank you.
Okay, so Dr. Gatt, kind of emphasized the point that, there's a lot of the literature that's published is the collegiate, it's the military, it's where they've sunk, most of the published research. But again, it still comes back to my high school population. What about the adolescent athlete? Few studies, it lacks good numbers. I mean, the one was 32, had an N of 32. The other one had an N of 19 participants. That's hardly, statistically significant. They don't use multivariate methods, and we get inconsistent or tentative results. Niemeyer's study, which Dr. Gatt covered, I'm just going to pass on that. But again, highlight the importance of early diagnosis of stress injury and it having a positive outcome or a quicker return to their recovery time. It's a Japanese study that was published, we found in a sports physical fitness publication. I'm not sure, in terms of high-profile medical journals. This was kind of the first study that we found that had good numbers. There was 222 reported stress fractures to 208 athletes. They were under the age of 20. Talked about males and females, pretty much an equal distribution of males and females. And they looked at stress fractures that came into, I believe it was 33 different hospitals in Japan, into the emergency department, and they followed them up. And peak occurrence was at age 16. Tibia was the most common. And they noted that 70% practiced 6 or 7 days a week. And if they visited, again, another study that shows if they visited before 3 weeks, they had a quicker return of 10.4 weeks versus if they came to the ER after 3 weeks of having pain, their recovery time was a lot longer. So early diagnosis is a key point. And pain is a warning sign. When they broke down, looking further at the Japanese study, 42% of them practiced 7 days a week, 27% were 6 days a week. So you're looking at almost 3/4 of them are 6 or 7 days a week of activity. And they also noted that 53% of them, even though they still had pain and they had an undiagnosed stress fracture, they still had pain. 53% of the kids just continued to practice. They just kind of dismissed the pain that they were having. And recovery time was a significant period of time. It's longer than the 4 weeks or maybe the 5 or the 6 weeks that frequently a lot of adolescent kids are given as a diagnosis for return. They also listed psychosocial factor as a risk factor. So the kids' motivation, their motivation to be active and play through the pain as being a risk factor for adolescent stress fracture. There's another study that was done, published in Pediatrics, where it was I believe it was called Growing Up Today study, where they surveyed mothers who were nurses, and they looked at just their daughters. And it was a pretty good number of girls that they surveyed and weren't necessarily athletes. It was just kind of a whole culmination of females. But they noted that there was some that had stress fractures and some of them had disordered eating. And they noted, and if as the hours per week of activity increased, the incidence of stress fracture increased. But they didn't find any correlation or relationship between Menard Z-score, BMI, the amount of calcium and vitamin D that they took in. But their major finding was that there was some sort of a link to family history of fracture. 14 in the 3 articles, essentially, very minimal articles that you can even look at for adolescent injury. 14 to 16 years old, prompt workup is considered important. There's a longer, till you get to the point of workup is associated with a poor outcome. Time with sport is an issue. The number of days practicing in the tibia is the most common. Question comes up, are females more common than males? That's an issue. I think there's a lot of different pieces that play into the whole puzzle. As I read, I had umpteen stacks of articles that I pulled off that were related to stress fractures. Drove my wife nuts because I would take up the dining room table with all my research articles I was going through, trying to find just little pieces from different articles and piece the whole puzzle together. In general, they occur more frequently in females than they do than males. Whites are more at risk than blacks. It's inversely proportional to age. So as age decreases, there's a greater incidence of fracture. And that also brings the question up, is age a risk factor for injury. There was one study that was done when they looked at, I don't know if we can get us, if they looked at adolescent bones. Is there a difference in the quality of adolescent bones versus adult bones? And it was a very limited study. They looked at they took actual bone samples from kids that had bone tumors, so they were pulling out actual bony samples. And they found that in general the adolescent bone was less stiff, weaker, and less mineralized. Wasn't a big study, wasn't a highly publicized study, but it lends some question. You know, is there a difference between the adolescent bone than there is between the adult bone? We know that they've got an open physis, so how does the open physis affect how the bone absorbs stress? With it being more cartilaginous than it is the firm or formatted bony structure. We know that they go through puberty through this adolescent time. There's hormonal changes in their growth velocity when they go through a growth spurt at that 13 to 15 years of age. What role does that play in? Can the body handle a lot of stress when they're going through those growth spurts? Their muscular development in this particular age group is a lot different than the adult. And then also strength and coordination. Do muscles work together? A lot of times you see the early or younger high school age kid being a little gawky and gangly. They're not real refined biomechanically. All pieces, I think, to the puzzle. It's also particularly important for females because through the ages of onset of menses, 11 to 18 is their peak bone building years. They lay down 92% of their bone strength. They don't have time to make that up as they get older. 11 to 18 is the peak time for their bone building years. Their hip is achieved by age 16, and during that pubertal spurt, they lay down 30 to 50% of their bone mass. Excessive exercise has been noted to delay menarche, and it switches off the hypopituitary gonadal axis, and it can impair bone mineralization, negatively affect height and trunk length. We particularly see this with the gymnasts. My daughter's in competitive gymnastics, and the number of girls on her team they're teeny. You know, it does affect their overall height. Are there long-term consequences for these kids that are suffering chronic bony stress injury during this primary growth period? Highest incidence, they found some studies lower bone mass in the lower extremity, decreased bone density. Many of these girls are on low-fat diets as they're trying to, you know, body image is very important. There's history of menstrual disturbances. There's lots of different factors. Dr. Gatt talked about the changes in menstruation and hormonal issues that go along with it. It strains the autonomic system. And is there long-term effects by disrupting what ought to be normal developmental processes during this time of development? Eating disorders play into it. Again, as we hit that negative energy balance where they're not getting enough caloric intake to meet all the demands, not just of growth and development, but of all their athletic activity. Nutrition, are they getting enough calcium, vitamin D? What's their body weight image, you know, of teenage kids? The bone quality. And this is a picture of my daughter as she was receiving a bunch of medals that day. There's a big emphasis of sports in America. The American culture is geared towards winning. Be all that you can be is very popular. There's emphasis from kids now, particularly in the high school level, for their kids to get the scholarship, to be the Division I athlete, to get the big contract. They're starting younger. They're specializing in an earlier age. There's multiple sport demands, meaning they may play 2 and 3 different sports during the same season. Club and travel teams, weekend tournaments. The net result is increased demands and increased stresses that's going on. It's a psychosocial problem that's affecting the issue as well. Training errors, fatigue, overtraining, old shoes. I found a study that showed that once your shoes reach 300 miles, the shock absorbency decreases by 54%. So improper shoes, you know, just because it says Nike doesn't mean it's the best shoe for their foot. Surface, is it too hard, too soft, inflexibility, a plethora of different problems that are associated to training. Biomechanical considerations. There's lots of literature written on the role pronation plays into it, forefoot, subtalar variations, muscular insufficiencies, external rotation of the hip. Lots of biomechanical factors that can play into the picture. There seems to be a universal constant in all the kids that I've seen with stress fractures is there seems to be some sort of a change as a key ingredient. Whether it's their training, the surface, their shoes, the intensity, the duration, there's some component of change that's involved. And I always just throw in, it's the rule of twos. They violated the rule of twos. Too much, too soon, too fast, too often, and too hard. Other pieces of the puzzle I think that you have to keep in your mind is genetics. The one story of the Growing Up Today study where they noted family history as a component. I asked the question, has mom or dad, brother or sister, anybody else in your family had a stress fracture? Is grandmother kind of shriveled up? Does she have osteoporosis or does anybody in the family have osteopenia? I read one study on the association of stress fractures with grandma or grandpa having a fractured hip, and how does that play into adolescents getting fractures? There's lots of different components. Stress among teenage kids is a factor, and particularly cortisol. Cortisol's got negative effects on bone health and bone development. And you can look at equipment, underlying diseases, medications, bone tumors. There's a whole gamut of different things that we as athletic trainers need to be kind of cognizant of to really look for. Again, noted changes, we normally see it within the first 2 to 4 weeks of activity, although there was a military study published by Gatt which showed that a significant number of stress fractures occurred within the first week of basic training. So it doesn't have to take 6 weeks for a stress fracture to develop. It's that change, it's that overloading of that recovery process, which is a big component. And always the notation of chronic pain ought to be a piece of the puzzle that you're keeping in your mind. It's a growing problem. There's little published research. There's lots of variables that we need to consider. And as you're looking at everything in my kind of trying to make sense of everything, are we seeing the whole picture when we see these kids that come through the athletic training room that say, I have shin pain? And also consider that, you know, by doing a shin tape job or helping to perpetuate this kid to keep them in athletics, are we doing what's necessarily right for them in terms of their long-term development and long-term health, bone health? Sometimes the injury that you see that comes through the training room may just be the tip of the iceberg in terms of what's going on with them in their situation. All the basis is laid. Lots of different questions. Dr. Gatt and I were talking, thought, you know, let's put together a survey and see if, you know, we can kind of track a lot of these different factors and see what really pans out for adolescents. Let's develop some literature. So we came up with an online stress fracture registry, and we wanted to gather data on adolescent bony injury. We had 61 athletic trainers contributing data from 21 different states. It's an ongoing study. We haven't decided what step we want to take next with where we want to go with the results. But it's an online database, quick and easy to take, takes no more than 5 minutes to complete. And it's a great way for us to kind of supplement our knowledge or gain more knowledge for adolescent injury. This is a list of all the different schools that participated in the study from all over the place. What are the factors we were looking for? What are the contributing factors? How does the basic developmental factors fit into it? How do the different training areas? What do vitamins? What does dairy? Stress, anxiety, all sorts of different factors. Let's put them all into a survey and let's see if there's anything that washes out. We looked at pain level, what's their clinical history, where are the most common fracture sites, how long does it take them to get diagnosed, what's their workup, who's making the diagnosis, and can we take this information to improve clinical decision making. To qualify for submission to the stress fracture registry is we had a criteria list that basically said you have to have a diagnosed stress fracture. Evidence of fracture on MRI, bone scan, CT, or X-ray, and it must be a high school athlete. The study basically occurred over a period of 2.5 years, but it was 2.5 school years, meaning during the summer we really didn't collect any data because schools closed. And we had 211 respondents, which made us the highest number of reported adolescent cases, all to athletes. Our breakdown was a few more girls than there were boys, and they reported 263 fractures. 69% were diagnosed by an orthopedist, 15% by a specialist, and 15% by the primary care physician. What's that say? Does that say either the primary care physician or the pediatrician isn't picking up these injuries, or the primary care pediatric physician is smart enough to pick up these injuries and is referring them on to the orthopedist? Not quite sure. Average age, as you look at boys and girls, boys is about 16, girls is about 15 when we break it down. 83% are Caucasian, and they're basically in 10th grade. Tibia is the most common. With boys, there's a trend towards significance, but it statistically didn't come out as a significant finding for the tibia. It was the most common with females, and of the females that had tibial stress fractures, it was the 59% of them occurred bilaterally. So even though they may have pain or be remarking of pain in one leg, when they do the comparison of two legs, frequently we're finding that the stress fractures are occurring bilaterally. 60% of all the girls reported that they had a tibial stress fracture. The foot was the second most common site, with second metatarsal being the most common. Then we ran down to the fibula, the spine, and the spine actually came out with some significant statistical analysis, but not a huge number of cases that we saw with the spine. Pain score, not reported in the literature, but something that I did in the athletic training room to say, kind of qualify your pain for me. Give me a subjective pain rating on a scale of 0 to 10. 0 is no pain, 10 is the worst pain you could ever imagine. We included that as a question on the survey. It has never been reported in the stress fracture literature before. Those that came in, the average finding was about a 7. So if your athletes are coming in, everybody that was coming in with stress fractures, 7, 8. There's a range between 4 and 10, but the mean was right at 7. It was interesting to note that with boys, when we saw femoral stress fractures, their incidence of reporting of pain was less than what you may find for a tibia. And then looking at the fibula, it was a little bit higher when we talked about fibular stress fractures on an athlete's remark of what they were having. Statistical analysis, as we looked at R values and P values, nothing really kind of came out statistically as we looked at hours per week, whether or not weight training affected, how many times they weight trained per week, how many seasons they were involved in during the year, how many sports per season. The statistical analysis didn't really show any correlation. We asked for pain expression, kind of what are the things they're telling you as they're coming through the door. We asked, do you have pain with ambulation, pain at rest, pain at night, pain that affects your performance, or pain only with activity? And generally there was about 2.5 expressions. They remarked that they had, on average, there was 2.5 expressions of pain from each of the kids, meaning that they would say that I had pain with ambulation and I had pain at rest, or I had pain with ambulation and pain at night. The most common finding was that they had pain that affected their performance, with a pretty high number of athletes. Ambulation was right there, with incidence of pain with rest, pain at night, and we did some kind of cross-analysis and looking at, what are the different factors that kind of correlate with pain. We looked at shoe condition, and what was funny is, like, my track coach response is, if you have shin pain, we'll just get a new pair of shoes. It's funny how those that responded that they had pain at rest were all, pretty much most of them were wearing new shoes. So, why is there that correlation? I don't know, maybe just one of those bizarre statistical findings. And then pain with ambulation. There's shoe condition, new shoes, there's 92% of them. I don't know You look at the statistics on night pain, pain at rest, pain with ambulation, and multiple sports, they got pretty good p-values. Now, is that just because statistically they just worked well, or is there something that's going on? I don't know. Other associated variables, as we looked at time to diagnosis, there was a difference between boys and girls. Girls tended to get there a little sooner than what boys did, and a range. There was a couple cases where there was over 180 days till a kid came for help. Further re-emphasizing that point, how kids are willing to run and work through pain. I had a track coach who printed up T-shirts for everybody. Pain is nothing more than weakness leaving your body. It's that kind of perpetuation of not a positive of expression of what pain is. We looked at prior stress fractures, not such a big deal. We looked at weight change. Have you gained or lost weight? Within the last 6 months, and the boys, there was about half of them had remarked that there was some sort of a change. So maybe they were in that growth spurt. Is that growth spurt, playing a factor of that? Prior fracture with girls. Have you ever had either have you ever broken a bone, before that you got your stress fractures? Does that make you more prone to having a fracture? We looked at hours of sleep, and boys reported significantly more hours of sleep than girls. Had good statistics that came out, but sleep is the time when the body is repairing. It's in the bony repair process, occurs during sleep. Do girls get a few more stress fractures because they're getting less sleep? Don't know. Looking at the stress, when we asked kids about the stress in their life, boys, 72% of the boys remarked that they had none or very low stress in their life, whereas the girls, 65% of them said their stress levels were moderate to high. And there was the American Psychological Association showed that there were some similar trends in that girls had a higher level of stress response than boys did. And the influence of stress. Those with moderate or high stress were more likely to report shin splints, or they had a higher remark of a pain scale if you broke down what their pain report was. We looked at diet, and we said, do you eat a balanced diet over the course of the day? And 80%, pretty much 90% of the kids are saying, yeah, I get a balanced diet. Again, it's a survey, so you're not sure, are these kids being straight up? What's a normal diet for them? Is it truly fit within the food pyramid, or are they really getting a well-balanced diet? We looked at servings of red meat. Boys get more red meat than do females. Well, that can have an impact when we talk about iron and its effects on stress fractures. We talk about supplements and vitamins. Boys were more apt to take supplements and vitamins. Servings of caffeine in the day. We looked at that, and boys had a little less caffeine intake than girls did. Dairy consumption. There was a significant difference between gender groups on dairy consumption, in that boys had a higher intake of dairy than did females. We looked at sports per year. Did you play 1, 2, or 3 seasons during the year? And as you look at the number of boys and girls that are involved in sports all year round, that kind of getting a break or getting away from playing sports has to be some sort of a factor in terms of stress injury. Was it your first time in competitive sports? Not a whole lot. I look at it as like the number of kids that I see that have got stress fractures are that freshman, sophomore. I was a little surprised that it was this low, but I'm guessing that because kids are starting sports at a younger age and organized sports at a younger age, they looked at it and responded and said, well, I've been playing sports since I'm 7, 8, 9 years old, rather than this is my first time in high school sports. Participation during the week, about 6 days a week was the average. We looked at average hours per week of activity with stress fractures, about 16 hours, and about 15 for girls. If you put it onto a chart, you can see there's a dramatic increase as we hit that 14 to 16 hours of activity. Is that a point where is that like a threshold that we're pushing our kids over at that 14 to 15, hours a week? Lower numbers when we get up here, but is that because there's not that many kids that are doing, exercising or playing games more than 23 hours, in a week? But there was really a threshold right at that 14 to 16 hours a week. Other sporting variables, we asked them, do you suffer from frequent athletic injuries? And it wasn't a real high response rate. It was only 23% of the respondents responded to it. But half the boys said, yeah, I get a lot of injuries. We looked at their aerobic fitness. In the military studies, they talk about aerobic fitness. So we asked the question, how fast can you run the mile? And the average mile time came out about 7 minutes a mile, which I think is a fairly decent mile time for an athlete. Training changes, they noted when we asked them, was there a change in intensity and duration and frequency, they noted at least 2.35 changes, and 70% of the boys noted that there was a significant number of training change that was involved in their stress fracture. Weight training, boys tended to weight train more than girls did, just a higher number and also a higher frequency during the week. By season, fall was the busiest time of year for stress fractures, as 50% of them of boys occurred in the fall versus 46. It was a little less during the wintertime and a little less in the spring, a little higher for the girls in the springtime. If you broke it down by sport, spring track, cross country, and winter track were highest for the females, whereas cross country, football, and winter track were of the higher for the boys. Spring track wasn't as big of a deal for the boys. I tried to look at individual positions, like what do you do on the track team? If you say that you're on the track team, what do you do? And is there an associated link between a particular event with track? And a third of them, of the females, reported that they were distance runners. During winter track, the difference flipped from distance runners to there was a higher percentage of sprinters during winter track. Most of the winter track, when we talk about the Northeast, occurs indoors and it's not on a formal track. They're running the hallways. So I look at it as more of the sprint trainers are inside and then they're pounding up and down on the inside of the hallways, whereas during the winter time, the distance runners aren't apt to just run around the hallways all the time. They're more apt to try to get outside and deal with the elements. Football ranked second for boys in terms of stress fractures, meaning that we had a pretty good number, and I tried to break it down by position. It was 19% of the total number of fractures that were reported by boys. Linebacker received a third of them. Defensive back, over half of them were to defensive players. And again, I kind of take this as a tainted statistic because a lot of times in high school football, kids are going both ways. We didn't kind of tease that out to say, are you a two-way player? It was just what they remarked in terms of their position. The most common point for athletes with football stress fractures was of the foot, and 50% of those fractures were occurring to the foot. In baseball, we had, of the baseball stress fractures, 6 of the 7 reported stress fractures from baseball, 6 of them were reported to the lumbar spine. So there's a pretty high incidence of lumbar spine stress fractures that were occurring in baseball as compared to any other fracture. Of the girls, 60% occurred to the foot. Girls lacrosse, again, a sport that is involved with a lot of running, occurred to the foot as well. So you can kind of look at, are there some trends from specific sports which make you a little bit more prone for a particular injury. If we looked at surface and we broke it down, we asked them to identify what the surface was that they did the primary amount of their playing and practicing on. Grass and a hard surface came out pretty close, with grass having the highest incidence for both boys and girls. And again, during the fall, a lot of the training does occur on the grass. And during the winter time, a lot of it is on the hard surface. We looked at shoes and tried to ask them to make a distinction were your shoes brand new, moderately used, or old? And we came up with 64% of them were moderately used or old shoes. If you tie it back into kind of that shoe research, where 300 miles on the shoes decreases shock absorbing capability, who knows, maybe newer shoes will help. I don't necessarily know that newer shoes are necessarily the answer. 77% or 78% of all metatarsal fractures occurred in moderately used or old shoes. Is shoe wear a contributing factor for metatarsal fractures? Could be an issue, something that we're looking at. Prior history of shin splints. Have you ever been diagnosed with shin splints? Again, only about 35% of the boys, pretty high number for the girls, over half. Did they last longer than 4 weeks? 75% of them said that they lasted longer than 4 weeks. Is that kid that went to the primary care doctor, or is that the kid that's just running through or perpetuating their pain? Do you get shin splints regularly? Almost 2/3 of them say, yeah, I get them all the time. You know, are we just not reaching those kids? Are we not making that connection that these kids are perpetuating the problem? Tibial stress fractures were the most common. The average age was a little bit lower than what the mean was as you looked at all of them overall. There was a good number of them were bilateral, and 17% of them remarked that there was more than one stress fracture when they reported their stress fracture. Of those 19 that reported multiple fractures, 14 of them were bilateral. There was some with the fibula and the calcaneus. Anterior pain was a common finding when we talked about where was the location of your pain on the bone. And anterior alone, so kind of those tension side stress fractures were very common with the tibia. We also asked for the location on the bone between proximal, middle, and distal third, and the majority of the stress fractures reported to the tibia occurred to the middle third, and about a third were down at the distal third, and then there was those that reported proximal pain. Their primary complaint was anterior, so anterior and proximal was a common finding when we talked about stress fractures in the proximal third. As we looked at the tibial stress fractures and teased out the number of hours that they practiced, 91% of them practiced or played sports more than 14 hours in a week. Came out pretty good with the statistics that we did as well. And then as the age of the athlete increased, the likelihood of a distal stress fracture increased, and it neared kind of significance, but didn't prove out completely. Fibular stress fractures, there was 26 reported fibular stress fractures. They had a little higher pain score than what the tibias were. The most common location for fibular stress fractures is in the distal third, and there was only 4 of them reported that there was bilateral fibular stress fractures. 69, or almost over 2/3 of them, occurred during the fall season. So the fall season is probably a risk factor for fibular fractures. Most of them occurred on grass, some of them on the hard surface, cross-country, track, and a good number of them were in varsity athletes. Metatarsal stress fractures were in the females, a little higher average. Second metatarsal is the most common, followed by the third, and then the first metatarsal in terms of incidence of fracture or location of fracture. Shin splints. 2 cents, Dr. Gatt, put in a good plug for it. Shin splints is a garbage term. I think we as athletic trainers, healthcare providers are doing a disservice to our athletes if we perpetuate the use of the term. There's no real medical diagnosis for it, and shin splint is a garbage term that can encompass a whole plethora of different things that can cause shin pain. I think we need to be smart and proactive and talk intelligently to our athletes, and not kind of, when they hear the term shin splint, they kind of dismiss it as it's not that big of a deal. Weaknesses of our study. Did we get every stress fracture that occurred at the school? Were they all reported on the online? I'm not sure that they were. Why do we only get 1 or 2 stress fractures from a school, and then another school we get 8 or more, or 15, reported from another school? Is there a collection bias from whoever's providing the data? We need to get better completion of all the questions that are on the survey, not just selected ones. There's no way for us to truly verify all the fractures that were reported on the test because we didn't have the actual films. We relied on the athletic trainers that were applying the data to verify that there was a fracture. We didn't address menstrual history, particularly because I felt that it put the athletic trainers in the athletic training room who are dealing with adolescent girls in a precarious situation at that point. That may not be the proper time for a male athletic trainer to be asking a teenage girl, what's your menstrual history? So rather than put anybody in a precarious situation, we just avoided the question. We asked general questions when it came to diet, mileage. We didn't keep track of exactly what they were eating. We didn't keep a dietary log. We didn't keep a mileage log. And we relied on the students to kind of remark what their food input was. Whether or not it was truly exactly what they said, there's no way of really telling. I think it's a good place for us to start on down the road as we continue to look at further research on bony stress, adolescent bony stress injury. As we do have a ton of information, it's a good starting point. How do you make sense of all the data? I think it's important to look at all the different variables that play into adolescent stress fracture, all the different things that we talked about, but you really have to look at the total picture. It's not just a sore shin that comes in there. It's not just a pair of shoes. It's not just that they're female. It's not just that it's their menstrual history. There's a whole gamut of different things that are going on. I think it's tough to make generalities to say, is there one particular thing that sticks out that you can take from the stress fracture registry and say, this is definitely a defining point that causes adolescent stress injuries. I'm not sure that we can do that. But we always have to remember that these are adolescent kids. They are going through their growth process, and what happens to them as adolescents may affect them for the rest of their life. So that being said, the value is it's the largest study on adolescent athletes that's ever been published. It's the first American study that we're going to submit for publication. It utilizes a pain score, which I think can be helpful. It highlights training issues in terms of hours, days, seasons, change of training. It looks at multiple variables. It utilized statistical analysis. It supported many of the prior findings, but it brought it all together under one umbrella. And it provides a basis for recommendations. When you talk about athletes that have got stress fractures, you can use some of this information to educate your athletes and your coaches. And it's also a basis for further research. You should consider a stress fracture if their pain is greater than a 6 out of 10. If their age is 14 to 16 years old, they underwent some sort of a change in their training, whether it's intensity, distance, mileage, or surface. Is it progressive bony pain? Dr. Gatt made the note of, pain after exercise, pain during exercise, pain completely during exercise, after exercise, and then during the day. It's progressing to night pain, pain at rest. Is there a pain progression that goes through the whole sequence? Pain that affects performance. Talk to your athletes. Have you had a fractured bone before? Do you have issues with fractures within your family? Is there some sort of a genetic link or a prior history that we can maybe look into? And look for the sport-specific fractures. Take time to look at a baseball player that comes in, says, my back's a little tight, but he's had back pain for 2 or 3 weeks. And say, maybe this is a kid I'm going to refer on because I know that spondylolysis can happen within the baseball population, or the basketball player with foot pain, lacrosse player with foot pain. Maybe we look for some more sport-specific. Adolescent bony injury is a problem, and the sooner you recognize it, the better the results are going to be for the athlete and better for their outcome. Talk to the parents. I always talk to the parents about talking to their daughters about the importance of a normal menstrual cycle. And also keep in mind, adolescent girls, oftentimes their first visit to the gynecologist isn't until they're 17 or 18 years of age. So sometimes if you're able to talk to the parents and initiate that conversation, you can help girls in terms of longer-term bone health and development. I don't think a multivitamin is bad, although the vitamin information is still kind of out there yet. Vitamin D, calcium, B vitamins, trace minerals. Eat the diet rich and colorful, I think is important. If you're going to take vitamins, take them at bedtime when your body's at rest and it's looking for minerals to help repair itself. Taking it at bedtime might be a better time to take it. Address biomechanical and structural issues. Don't overlook the value of a good night's sleep. And look beyond the shin pain. Take time to ask the athletes, some of the other questions that may be associated with what's going on, and try to direct them to the physicians that are going to help them out in the process. The sooner we recognize that there may be a problem or that there's something going on, the better the result's going to be, and hopefully we don't lose as many kids out of normal physical activity. I'd like to thank Dr. Gatt for helping me with the stress fracture registry. Elaine Coleman helped with the webpage development. Dr. O'Hara helped with the statistics, and Dr. Schoenfelder also helped to make some sense of all the different stats and statistics that we had. But most importantly, I'd like to thank all the athletic trainers that took the time to actually complete the survey and to be a part of the study. I think it's a very good sign that our profession is willing to work to make change and to help to find answers and to make a difference in the whole adolescent injury situation. Thank you.